And I do mine afterwards because I can't do the technology thing. So
Well,
that's fine.
if
So
it
let's
happens,
get
I can
started.
always.
Let's get started. I'm going to be introducing Dr. Bolton. So Dr. Bolton is going to be talking today about thinking about suicide as psychiatrists and as psychotherapists. And I think he's the perfect presenter for this topic. If we look at his training, well, he trained in psychiatry at one of the top places in the world, the University of Pittsburgh. And then he completed a psychoanalytic fellowship in one of the most distinguished psychoanalytic centers in the world, the Boston Psychoanalytic Institute. In addition to that, he has studied anthropology at one of the most distinguished universities worldwide, that is Cambridge. And also and that was social anthropology. And he also did another Master's of Arts at Michigan State, also in anthropology. So Dr. Bolton is currently a psychiatrist. He's a professor of psychiatry at UNM. And his clinical work is, and I know he's very committed to his work. That's the ACT team, the Assertive Community Treatment Team. I know he's very dedicated to patient care. He also leads one of our most important clinics, that is the Psychiatry and Psychology Faculty Clinic, where we, of course, serve faculty members, residents, and so on. He has a number of positions within the Health Science Center. He's the Associate Vice Chancellor for Academic Affairs. He's the chair of the HSC Institute of Ethics, the Director of Professionalism at HSC, chair of the UNMH Ethics Committee, and most importantly, he's the Director of Ethics and Professionalism in our department. It is, Dr. Bolton is quite unique, not only in terms of his training, but also in terms of the role within the university. We're very proud to have Dr. Bolton as a faculty member, and I'm honored to present a very distinguished faculty member and fellow Correliano. Dr. Bolton, please get going.
Dr. Tone, thank you so much. That was a very kind introduction. And the hat I'm going to be wearing today is the clinician hat. And I should say something about the title. The title, a more accurate title to this talk, would be Thinking about Suicide as Psychiatrists, Psychotherapists, and Psychologists. Suicide has become the new hot ethical issue, and we're at the center of it. But today, I want to talk more about suicide in our clinical work, how we think about it clinically, than as an ethical issue. That's a different talk. So I'm going to describe two different ways of thinking about suicide that we practice as clinicians. One is as an event, and the other is as an action. And I'll end up by encouraging you to resist your training and actually to think about suicide as an action before you think about it as an event. And I'll tell you how I approach patients who are suicidal in the psychiatric emergency room. So before we go on, I have to acknowledge that suicide can be a very difficult thing to talk about publicly. It's a topic that elicits very strong emotions and sometimes rigid thinking. It can elicit great sadness in people who've known somebody who has committed suicide. And I'll be talking about it clinically as a clinical problem, much like an oncologist might be talking about cancer. But I hope that the way I talk about it won't come across as insensitive. I really want it to be useful to clinicians who have to assess patients for suicidality, occasionally grieve patients who have committed suicide, and also useful to family members and friends of people who have committed suicide. So that's really my intent. So what is suicide? Simply, for today's purposes, it is acting with an intention of killing oneself. It's self-killing. It's one type of death, and coroners and forensic pathologists distinguish it from other types of death, like natural death and accidental death and homicide. Our thinking about suicide is obviously affected by the social milieu in which we live and work. And for much of the history of pre-modern and modern Europe, suicide was immoral and illegal. It was a sin against God, and it was a crime against the state or the crown. And the possessions of the suicide, the person who killed himself, could be confiscated by the state. The body could be desecrated, and it couldn't be buried in a church cemetery. And it wasn't really until 1961, in England anyway, that laws were passed to repeal the laws against suicide. And around that time, and from that point on in the US, laws against committing suicide have been progressively repealed. So now it is not illegal in any state to commit suicide. But suicide has become a mental health problem. That said, it's something of an anomaly to psychiatry because it's not a disorder, it's a behavior. And since 1980 with DSM-3, psychiatry has really changed its attitude toward behaviors and all the murkiness of motivations and unconscious drives and that sort of thing. Nowadays, we tend to see our objective as diagnosing and treating diseases and disorders. And we've kind of gone mute on motivation. And we've converted the behaviors that we used to study into disorders like eating disorder and substance use disorder and gambling disorder and that sort of thing. We have not yet created a suicide disorder, but some people have been pushing for this. So before we go on and talk about suicide in general, I want to describe a particular suicide that I've thought a lot about, as any of us will when we lose a patient to suicide. So when I met Susan, obviously not her real name, she had been a patient on the ACT team for about 5 years. She was in her late 30s. She had graduated from college. She had given birth to a daughter. And she had developed postpartum depression. And then she was treated with an SSRI and then developed mania. And that was the first inkling of this illness that came to really change her life dramatically. When I met her on ACT, she had separated from her husband. She was using drugs. She had been sexually assaulted. She couldn't keep jobs. She'd lost custody of her daughter. And the medications had caused her to gain weight. And she felt she had no control over her life. She'd been hospitalized at our hospital at MHC 7 times and other places, including the state hospital. In December 2014, she was taken to jail. And in retrospect, she was probably manic. She might also have been on drugs. But while she was there, she acted in a way that caused the jail to charge her with 2 felonies. She was in jail and she was charged with 2 felonies. After she was released, she came back to ACT, but the felonies made it impossible for her to get a job, to get a position even as a volunteer. She couldn't find a place to live. She started using drugs again. And my notes from meeting her over that time repeatedly used the word demoralized. That's how she seemed to me to be. She was demoralized. And after about 4 months after she was released from jail, she was living in a motel room on Central. And one day a cleaning lady found her dead on the bed and she had drunk engine coolant. So when I think about Susan, I have 2 minds about her. I think about all of the risk factors that came to define her life. And I find myself thinking it was inevitable that she was going to kill herself. But then I think the other side thinks, what about this decision to buy or to steal the engine coolant, to take it back to the motel room? I imagine her opening the container and drinking it. And what did she feel or think as it was killing her? Why did she do it? And why did she do it in that way on that day? So the first way of thinking about suicide, or Susan's death in particular, is as an outcome, an event, or a consequence. She had accumulated just too many hazards. It was just a matter of time before she killed herself. The other way of thinking about suicide is that suicide is something that she did. She acted on her intentions, on her motivations. So in the remaining time, what I want to do is I really want to examine these two different ways of thinking about suicide. And I'll argue that only by considering suicide as an action can we actually develop useful ways of thinking about it as an event. So suicide as an event, this is really the predominant way that we have of thinking about suicide. It's how we talk about it at conferences like this, at CME, at medical students and resident lectures. And according to this way of thinking, suicide is the result of a causal chain. And really, this way of thinking isn't that different from thinking about the weather or cancer. These are all events and they all have causes. And our job is really to identify the causes so that we can explain the events. And once it's explained, then we can predict or prevent it. So in terms, the first step in doing that, of course, we have to have an accurate understanding of how frequent is it? You know, how often does it happen? What's its distribution? We have to count it. And in order to count it, we have to be able to identify a death as a suicide. Now, some suicides are really not counted as deaths because they're counted as some other kind of death, a natural or an accidental death. This can happen for lots of reasons. It could be that, you know, the coroner doesn't want to harm the family. You know, the pathologist has to decide whether to count a person who chose to withdraw life-sustaining treatment like a dialysis, whether to count that as a natural death or as a suicide. So there's some uncertainty in our questions, but given that, how common is it? How common is suicide? And most estimates put the overall frequency of suicide in the community between 0.02% and 0.6%. And so we can convert those incidents into population rates, and then we can compare rates. So, for example, the annual US rate until this year anyway, or last year, was 14.2 out of 100,000 people. And the rate, and so that allows us to compare. By comparison, New Mexico had double that rate. We had 24.8 out of 100,000 people. So rates can be ranked. And for years, suicide has been in the top 10 causes of death. Last year, interestingly, suicide was bumped out of number 10 into number 11 by COVID. And just released yesterday, or just reported yesterday, there was a 6% reduction in suicide during the pandemic. How do we make sense of that? That's completely the opposite to what we predicted. Anyway, once we start to count suicides, we notice patterns. It's higher in some groups than others, but we want to know why. Why is it higher in some groups than others? And this is really the work of normal science in risk factor research. So risk factor researchers have lots of different ways of studying any event, and suicide in particular. Experimental methods, observational methods, and the goal is to identify these associations and to assess them for causality. That's what we want. And each method will generate certain forms of knowledge and data of a particular type. And some of these methods allow us to make less risky arguments about suicide or about the event in suicide. So experimental studies, really, those are the best, they're the strongest ways to connect cause and effect causally. But as you can imagine, studying suicide experimentally is a little difficult. We can't really use suicide often as a primary outcome measure. So we don't have a lot of experimental studies. What we do have is a lot of observational studies. And these are various types, cross-sectional studies. That's a sort of snapshot or a moment in time description of associations. But because it doesn't allow, it's just a snapshot and it doesn't give us any sort of time dimension. And that means we can't use it to explain causation. Because the cause obviously has to be antecedent to the outcome. So we have countless correlational studies, and sometimes they do reveal something surprising, which causes us to dig in using other methods. The case control studies, these allow us to compare the incidence of an event like suicide in two different groups. One group has the risk factor, another one doesn't. And really most of what we know about suicide as an event comes from cross-sectional and case control studies. We do actually have, we've made use since the 1950s of a retrospective method. We call it the psychological autopsy. And starting in the 50s, researchers used this retrospective method to look for testimony or documentary evidence to retrospectively determine whether the death was a suicide, and also, what factors might have been causative. So really, these studies have given us evidence that about at least 90% of suicide deaths are associated with mental illness. That doesn't mean they were caused by mental illness, but they were associated with mental illness, over 90%. Now, obviously, armies of grad students and research faculty and private companies like internet giants are generating mountains of associations. And we have lots of correlates. Most of them are not that useful to clinicians. For example, just to know that more suicides occur on Wednesdays and Thursdays, or more suicides happen in September, doesn't really help us much clinically. So what do we know that's useful and true? Well, we've revised our estimates of incidence of suicide in general, and our estimates of the correlation between affective disorders, which is one of the strongest causes, and suicide. We initially had estimates that around 15 to 20%, and now the estimates are around 8%. I'm quite reluctant to go into this water because Dr. Tone is an international expert in this, so it is with huge trepidation that I talk about these things. But if I'm way off, we can talk about it at the end. But
Dr. Bolton?
Yeah.
Are you? Do you have slides?
I don't. This is very old school.
Just want to make sure.
I have one or a couple at the end. So if you can allow me to share screen, I'll do that from my computer, if that's possible. So we know things about the event. We know that the rate of suicide in non-affectively ill people is 0.5%, for example. And we know that the lifetime risk of suicide for patients who have been hospitalized for suicidality is less than 10%. It's around 9%. So we've calculated lots of risk ratios, or odds, relative risk or odds ratios, and meta-analyses have helped us to sort of make sense of all these things. But knowing that a risk factor has a high relative risk in itself doesn't really tell us how that risk is going to be increased or decreased by other factors, whether they're protective or exacerbating. And we're dealing with very complex systems. There's no single sufficient risk factor to explain suicidality. So the outcome of interest, it's really sort of an emergent properties of all these interactions of the risk factors. And at the moment, we really don't understand the complexity of the system, the complexity of these interactions, either in the abstract and certainly for individuals. So, we do have this goal from this event-based perspective of explaining suicide, identifying it, predicting it, and then preventing it at the individual and population level. So how close are we to achieving these objectives? Do we really have useful causal risk factors? We certainly have a lot of associations, and we certainly have some strong risk factors, presence of medical illness, mental illness, substance use, all the usual ones that we know, but they're not very specific. And ultimately, we have to decide whether a risk factor is going to be useful. And if it's going to be useful, it depends upon how we make use of it. I'm going to talk about that at the end. How do we make sense of these risk factors? So do these risk factors allow us to foresee, which is a legal term, suicidality better than not having them? This is not a trivial issue, because given it's our responsibility and our authority, that allows us to involuntarily hospitalize members of the community. This authority is predicated on our ability to predict suicidality. And a very commonly cited study out of Pittsburgh estimated that we're actually accurate in these assessments of violence, which includes suicide, 1 in 3 cases. And that's well below the rate of proof, the standard of proof that we need in a civil case, for example, which would be the preponderance of evidence. So we're not particularly good at predicting suicide. And why is that? It's obviously something to do with the phenomenon. The phenomenon is quite a complex phenomenon. It's obviously something to do with our methods. And until recently, we've been really relying on most of the same methods for generating these risk factors and associations. And one recent meta-analysis of studies of the risk factors of suicide performed over the last 50 years concluded, and I'm going to quote, it concluded that prediction based on risk factors was only slightly better than chance for all outcomes, and no broad category or subcategory accurately predicted far above chance levels. Predictive ability has not improved across 50 years of research. Now, some researchers are making use of newer sources of information like the digital universe, and there are some initial reports that algorithm-based machine learning is more accurate than clinicians in predicting suicidality. And obviously, machines have a lot more information than we can get in a 30 or 60-minute session. And this sort of data mining might actually reveal new risk factors. And companies, I heard this on the way home the other day, I heard a company advertising its service, and its service was surveillance of students' chats and alerting the schools when there seemed to be evidence of suicidality. So we've got machines now, but they're going to reach a limit on how useful they are. Not every suicidal thought is going to be encoded in a Snapchat conversation or a web search on suicide methods. So it's complicated, obviously, and we don't have any diagnostic test like other branches of medicine, and we have to use risk factors instead. And when we use risk factors in this way, we will have better or worse precision or predictive value. Now, positive predictive value, I hope Dr. Nuremberg isn't on here because he's the expert in this. Again, going out on a limb, but a positive predictive value for a test or a risk factor really is how well it identifies true positives. And a negative predictive value describes how well the test identifies true negatives. In other words, can we identify truly suicidal patients and truly non-suicidal patients? And unlike sensitivity or specificity of tests, predictive values, they're not fixed for a particular test or risk factor in our case. They're influenced by the prevalence of the outcome or the event that we're interested in. So if an event like suicide has a very low prevalence rate, by definition, its occurrences are going to be very rare. And there's a greater likelihood that any particular or single occurrence will be falsely identified. In other words, because we have such a low prevalence rate, the test will generate too many false positives. This means that we're at a greater risk of calling somebody suicidal than we should. And then, of course, we might act on that by hospitalizing them and so on. So the take-home message is that although it is true that most people who kill themselves have a mental illness, it is also true that most people who have a mental illness do not kill themselves. So have we reduced the rate of suicide? We've certainly been very assertive in treating some of the more common or powerful causes of suicide, like affective disorders. And we've been prescribing antidepressants at far higher rates now than we did in the 90s. And there's some interesting findings have come out. And again, I'm going to have to defer to some of the experts in the Zoom room, but some ecological studies of the association between the rates of antidepressant prescribing and suicides within various national health systems reveal a mixed picture, and it's mixed at the level of country. In other words, some countries have had a significant reduction in suicide with this dramatic increase in antidepressants prescribing, and some haven't. An Italian study reported that there was a 50% increase in the use of antidepressants in Italy, but it was associated with a slight increase in suicidality amongst males and a slightly larger decrease in suicidality amongst females, and no change in psychiatric hospitalization. In Sweden, there was also quite a marked increase in antidepressant prescribing, and this resulted in a 30% reduction in suicides for men and women. But a different study showed that it didn't change the suicide rate for women who are younger than 30 or over than 75. So it's these mixed patterns, both by country, but also within a country, that's confusing in terms of the relationship between our primary treatment for this risk factor. Overall, our CDC reports that between 1989 and 2019, there was a 33% increase in suicide rate. And suicide has been in the top 10 leading causes of death in the US for many, many years. So what does that mean in terms of our thinking of suicide as an event and our acting on that thinking? Obviously, this way of thinking is at the foundation of scientific thinking. We're trained to think in this way, and we know it works to explain natural phenomenon. And obviously, a famous, is probably hackneyed by now, but a famous example of this approach was in the press conference where Richard Feynman, the famous physicist, explained the space shuttle explosion. As a result, he held up an O-ring, and he said the cause of the crash, the explosion, was a frozen O-ring seal. This way of thinking is very powerful, and it encourages us to think about what are the frozen O-ring seals for suicide. But it may be that humans are sufficiently different from space shuttles, obviously they are, but to question this approach, humans, unlike spaceships, can choose whether to launch or not, and they can choose for good reasons or bad, which means that the search for risk factors is not ever going to be fully sufficient to explain or even understand suicide, and certainly not to predict it. So before we move on to this other way of thinking that I've promised, I want to promote a now very old, outdated causal risk factor. Now, risk factors go in and out of fashion. Some risk factors are rightly retired because they're no longer useful or they're invalid or what have you. But some go out of fashion because the theoretical model that endorsed them went out of fashion. You know, think about Marxism, that's gone. Psychoanalysis is probably largely gone. And this is what happened with demoralization. Demoralization had a really good run as a risk factor for suicidality. It was promoted by researchers starting around in the 1940s and 50s, when we were less focused on diseases as a field. At that time, we were more attentive to the power of circumstances to induce suffering. Perhaps we were more sensitive to this because the researchers had gone through world wars, depressions, maybe it was existentialism. One of these researchers, Jerome Frank, was a Johns Hopkins psychiatric researcher. And for those who remember Dr. Uhlenhuth, he was a resident under Dr. Frank and had some fantastic stories about Jerome Frank. But Jerome Frank famously promoted two important ideas in his book, Persuasion and Healing. First, he argued that it's in the nature of humans, and likely other species, you can think about the Harlow monkey studies, but it's in the nature of humans at least to become demoralized, to be undermined by feelings of hopelessness and helplessness when they are in certain situations. Situations that can create demoralization, induce these feelings of helplessness and hopelessness, and the temptation to give up. suicide can be considered as giving up. Secondly, he argued that because it is an existential state, demoralization is best treated by psychotherapy and not by medications. Now, as a field, we talked about demoralization as related to suicide for quite a few decades, but when we started to use the word depression, demoralization kind of faded away as a word and as a concept. Depression is a disease, and there was less interest in thinking about context and more interest in figuring out the molecular changes or the receptor level changes of this thing that we call depression. I actually personally find demoralization as a clinician very useful as a risk factor for suicide. I think it captures what I think is essential to many kinds of suicide, the sense of powerlessness, futility, hopelessness that can take hold of a person. And some suicide notes convey this. They convey the sense of demoralization. And I'm going to try to put up my very few slides here. And this is a quotation from, this is a note by Virginia Woolf to her husband. She wrote, "Dearest, I feel certain I'm going mad again. I feel we can't go through another of these terrible times, and I shan't recover this time. I begin to hear voices. I can't concentrate. I can't fight any longer. I know I'm spoiling your life, and that without you, you could work. You see, I can't even write this properly. I can't read. If anybody could have saved me, it would have been you. Everything has gone from me but the certainty of your goodness, and I can't go on spoiling your life any longer." So one could argue that it was a mood disorder that killed Virginia Woolf. I believe that the mood disorder might have been a necessary condition, I think it was, for her suicide, but it wasn't sufficient. And I think demoralization caused her to give up. She had no reason to hope. So all of this really is to encourage you to include demoralization in your kit of risk factors, along with drug use and impulsivity and family history and all of that. So we've talked about suicide as an event. I want to switch now to this other way, thinking about suicide as an action. So we've talked about it as an event, something that happens, that has a cause. It's an event to be explained, just like myocardial infarctions or cancer. And this way of thinking is really based on deterministic metaphysics. It presumes that a cause has an effect, which will become cause for another effect, and so on. And in the strongest form, this determinism, in the strongest form, a cause will have an inevitable effect, which will indeed then cause an inevitable sequence of effects. A less strong or a more moderate version of this is that a cause has a probability that it'll have an effect. So determinism is insinuated into much of our thinking, and it shows up in surprising places. The biopsychosocial model, which we talk about just probably to medical students only, is deterministic. A lot of psychoanalytic theory is actually deterministic, in contrast to psychotherapeutic therapy, which often isn't. So an alternative to this way, this deterministic way of thinking about things, is to believe that as humans, we're not fully determined in our thoughts and actions. We're not captives to causes in this way. And we're able to assert ourselves, assert our will. And this view is embedded in a very different way of thinking about suicide as action. And my intention to presenting this isn't to disprove the first way of thinking. It's more to bring to awareness some of the things about suicide that are ignored or hidden in that first way. So if suicide is an action, then the person is recentered as an agent, and this creates space to examine the decisions that the person actually makes and how the person makes those decisions. It also, thinking about suicide as an action, also makes it possible to expand ethical investigation beyond the injustice of, say, how determinants are distributed, to include moral action. You know, is it right to commit suicide? That sort of thing. So this way of thinking it's been implicit in one of the English phrases that talks about suicide, to commit suicide. And that phrase emphasizes that suicide isn't just a happening. A person makes it happen. The logotherapist, or the therapist, Viktor Frankl, reported that when he was in concentration camp, Nazi concentration camp, he witnessed prisoners giving up and soon after dying. And for him, the giving up was an action. And he spent a lot of the rest of his career talking about not giving up. So what do we mean by action? In philosophy, this is actually a fairly complicated field in philosophy, but for our purposes, we're going to just distinguish between action, reflex, and habit. And actions can be rational or irrational. They can be considered or impulsive. They can be self-minded or other-minded. They can be moral or immoral, but they all convey some sort of commitment, a sense of commitment, of intention or motivation. And intention refers to what the person wants to achieve or what the person wants to cause. Motivation is the reason for the patient wanting those things, wanting to have those sorts of objectives. And my own thinking about this and these distinctions really started during residency when I read Karl Menninger's 1938 book about suicide, Man Against Himself. And Menninger argued that a suicide has meaning. It reveals something about the person, about his or her intentions and motivations. They're implied in the action. So he argued that we should interpret suicide, not just explain it. So that means that as clinicians, we really have to try to interpret the intention of the person who's thinking about suicide, including how strong it was or is. You know, people are often quite ambivalent about killing themselves, not surprisingly. Not many people approach death as Socrates did. Most of people who commit suicide must be racked by ambivalence. But the goal is to interpret that. What do they want to achieve? People may not want to die. You know, when we're in the psychiatric emergency room, suicidality is presented. They don't really want to die often. They really want 3 hots and a cot, or to hide out. Steve Lewis talked about a patient early in his career who presented with suicidality. And it was really because the mafia was after him and it was the safest place he could find to hide. So trying to figure out the intention is part of our job. We also want to know the motivation. That's the why question. Why are they suicidal? And motivations are not always accessible to the person who has them, and they're not always admitted to. So we often have to infer them. And I'm going to present to you in another slide a variation on a common typology of suicidal motivations. And the first motivation is I want to die. I no longer want to exist. There is nothing left for me to do, and it'll only get worse. And this comes out of a sense of hopelessness. The second motivation is I want to escape. I want the situation to end. If it could be ended in any other way, I might not want to die, but this is the only way. So early in my career, I had a patient who jumped out of a window. But it wasn't, she didn't want to die. She had akathisia, and it was unendurable for her. You know, Virginia Woolf's cycle of depressions must have been unendurable, and she wanted to escape. And this is a sense of helplessness. Third is, I want to help someone. This is sometimes called altruistic suicide. It describes a motivation to benefit someone else, even if it's going to cost you your life. And it really implies that I value the lives or the benefit or the well-being of others more than my own. You know, I might believe I'm a burden to others, so I should not prolong their suffering. So this suicidal impulse and motivation comes out of love. Fourthly, I want to hurt someone or something. These are sometimes called revenge or hostile suicide. So I might want to cause somebody else to feel pain or sadness or guilt, or maybe some of those feelings that I've got myself. It might be a protest suicide against a person or a group or something like that. Think about those monks who immolated themselves in the Vietnam War to protest against the war. So this motive comes out of a sense of anger and injustice. Fifth is, I must atone. I've done something so bad that the only way I can atone is by ending my life. It's necessary to set things right. And this comes out of a sense of guilt or a hope for redemption. And lastly, I must die. I must do my duty, even if it costs me my life. And my duty is more important than my life. So think about those men in World War I trenches who went over the top of the trench to almost certain death. This was a sense of duty. So these are common motives that I think we can look for in people who are assessing for suicidality. There's another thing that I don't think is a motivation. It's more like a circumstance. And this is when the person feels forced to commit suicide. The patient doesn't want to die, but feels powerless to oppose this sort of coercion. And this was not uncommon in the ancient world. Socrates and Cicero committed suicide under these circumstances. And it's really a sense of acquiescence. So those are some of the motives that we can look for. What are the consequences of doing this? What are the consequences of thinking about suicide as an action? We talked about consequences of thinking about suicide as an event. But if we think about suicide as an action, it recenters the individual as an agent, as a decision maker. And that person, as agent, can be interrogated about why do you want to commit suicide? What do what's driving this? And if we are attuned to these motivations, then we can meet the person as they are. We can wonder with them whether they really are ready to die, whether harming somebody else is that important, or whether it's the only way to atone. Or we could try to ameliorate whatever the condition was. So that woman who jumped out of the window, obviously the thing to do was to treat her akathisia. It might also lead us to talk to people after they survive a suicide attempt. We don't often do this. It's astonishing to me. We don't actually talk to people about what happened. What do you think now? What do you feel now? What's changed for you? It's almost as though we think our job doesn't involve that. Our job is to adjust, risk factors, that sort of thing. And obviously it is important for us to try to change cognitions, maybe hospitalize the patient or use ECT. I'm not arguing against that. But I am suggesting that thinking about it in these ways, exploring with the patient, the person, what was the motive? What was driving it? It isn't the case that if we think about suicide as an action, that we're saying that it's all legitimate or it's all rational. Actions can be irrational, and determining that is part of our job. So just to summarize, I've talked about these two ways of thinking about suicide that we have. They're not the only possible ways of talking about it. But if there are at least two ways, then we have to figure out which is the best way, which are we going to privilege. And for myself, I have decided that there's more to gain by thinking about suicide, firstly, as an action. It helps me stay focused on the patient. And it makes me want to try to help them to defy the odds. So I thought in the last few minutes, what I would do is present to you how I approach patients who are suicidal. And if time allowed, I would love to hear how other people do it, because we can all learn from that, but we don't have the time. So I'm going to present this. So the first assumption, the operating assumption, is that if a person's going to commit suicide, the person has to do it. An unoccupied neuroreceptor isn't going to kill the person. I'm interested in the self that would kill the self. And so, borrowing from transactional analysis, you're going to think I have not read anything new since the 70s in psychiatry with all these things I'm trotting out. But I think transactional analysis actually is quite helpful, and it invites us to think of three different selves to a patient, or ego states: the adult, the parent, and the child. And I'm most interested, when I'm talking to somebody about suicide, I'm most interested in the adult self. That's who I want to interact with and ally with. And I presume this self can be reasoned with, and it can express itself in ways that I can understand. But sometimes I can't find that adult self. I can find the parent self. That's that altruistic, other-minded self that's responsible in different ways, like responsible to children or dependents, that sort of thing. That's my second choice. The parent self isn't immune from suicidal impulses. If you think about Andrea Yates, the woman who drowned her children while in a postpartum psychosis, I presume that her mother self was part of this, was the agency in that. Sometimes I can't find the adult self or the parent self, and that all I can find is the child self, that impetuous, narcissistic, limited self. And perhaps because I'm not trained in child psychiatry, I really don't feel comfortable interacting with that child self. I don't find it a reliable ally. So when I'm trying to figure out where these selves are, I have to decide which self is dominant at the moment. Has the child self locked the adult self in the basement and is now running amok? And if I can find that adult self, I want to know if it's compromised. Is it in a state of pain or hunger, that sort of thing, or hopelessness that means that it's really not able to rise to the occasion? One trap to avoid is to think that a patient cannot be engaged in this discussion. The adult self cannot be engaged in this discussion or exploration because they have a mental illness. One of the things I've learned from ACT patients is how much of the self is left over from after serious mental illness. There's still an adult self that can be accessed. So the second thing I'm looking for is, what is the intention? What does this person want? Are they committed to killing themselves? How ambivalent are they? What's the nature of their ambivalence? Are they committed to the outcome, the suicide, but not to the means? Are they reluctant to do it themselves? Do they want somebody else to do it, like the police or me? Do they want me to save them? Do they not trust me? Am I in their way? So I'm trying to get a sense of their intention. And then thirdly, I'm looking for their motivation. Why are they thinking about suicide? What's driving this? So I have to try to infer from the information that I'm getting in the conversation, what is the primary motive? Is it to die? Is it to escape? Is it to hurt someone? Is it to help someone? Is it to atone? Then I will refer to risk factors, but the risk factors have to be clinically useful. They have to help me try to understand a person's action and decision-making. So I look at risk factors that are related to state or trait. So state risk factors, mood state, depression, mania, that sort of thing. It's not the state that's important, it's what the state does to somebody. So when somebody's depressed, their sense of future vanishes, time future vanishes. So that will have impact on the action. So that's why I want to know what state they're in. You know, if they're anxious, they're not hearing me. I want to understand the process of their thinking. What distortions are they putting into place? You know, I want to know about the content. Are they nihilistic? I want to know about intoxication. Anybody who works in PS, most of what we see is drunkest idols. So that's going to go away. That's just a state. I want to know about loss or grieving or loneliness or demoralization. one thing I'm looking for is anger. Anger drives suicidality predictably, and there are four things that make people angry: humiliation, injustice, feeling thwarted, and a failure of expectations. So I'm looking for evidence of those things that might be driving the anger that's driving the suicidality. Then I look for traits, not something that's temporary, but is there something that's part of them, part of their enduring sense of self that I have to reckon with? Are they impulsive because of a brain injury or a personality disorder? Are they hostile? Do they have dependent traits? Are they stably unstable? So these are all things that we all assess in the psychiatric interview. And they are risk factors, but they're far more reliable and valid than many of the risk factors that we put at the end of our assessment, gender, age, ethnicity, those sorts of things. The last thing I want to get a sense of is the social network. Do they have a reliable social network? Is it influenceable? Can we help the social network? Is the social network defined by hypercriticality or hyper-intrusive comments that will make it difficult for this person to survive? So those are the things I'm paying attention to when I'm trying to get a sense of the likelihood that this person will act in a way that they will kill themselves. So coming back to Susan, how do I think about Susan? Admittedly, she had all the usual risk factors that we pay attention to: mental illness, previous attempts, substance use, trauma, affective disorder, unimaginable losses. Those are all true. But I also wonder why she killed herself on that day, and how do we understand her action? What was her motivation? Did she want to leave life? Did she want to escape these constant assaults? Did she want to hurt her ex-husband who took her child away, or the person who filed the felonies? Did she want to protect her daughter? What was the truth for her at that point in time? And the truth is, we won't know. But the other truth is that she had a choice, and that she made a choice. And because she could make a choice, that's actually what makes her death a tragedy. So I am going to stop there and try and read the chats, but I would welcome any comments, corrections, anything that came to mind in that rather rushed march through suicidality.
Hi, Jonathan. Avi.
Hey, Avi.
So I wanted to thank you very much. That's you had a very philosophical and anthropological presentation, which you don't often hear, and I really appreciate the thoughtfulness in there. I could add a little bit more about youth suicide that I thought might be helpful. So unlike with adults with COVID, the rate has increased in youth, especially middle school and high school. And the thing that they connected to the most is social isolation as perceived by that youth, as well as increased bullying and social media. So those seem to be two significant factors. The other thing is that you mentioned about that we don't ask people who survive suicide attempts what goes on. And there's a huge literature of that for people who survive life-threatening suicide attempts. And what's heartening about that is between 95 and 97% say that within seconds of jumping off the bridge or taking the pills, they said, why did I do that? And they don't go on to make any major life-threatening suicide attempt after that first. The other thing that I wanted to add is that a lot of studies, more for youth than young adults, but I'm guessing it's the same for adults, is that what they describe is none of the risk factors that we talk about. What they talk about is sort of misery in their mind, psychological torment that feels like unrelievable. And a lot of them compare it to like terminal cancer, like nothing will get it out, no radiation, no chemotherapy, no surgery will work. And the last thing is that you mentioned briefly about a situation where somebody had significant akathisia. And in the literature about why do prepubertal children and pubertal children and adolescents have somewhat of an increased rate of suicide with some of the antidepressants, it's actually the same with antipsychotics. Anything that causes severe akathisia, and that again goes back to the misery in their mind. There's nothing, no posture, like we all know. They can't sleep, they can't sit still. It's just, and it's actually another corollary in that is the elderly who have tinnitus. It's unrelievable. That has been a cause of suicidality where nothing will relieve that pain and anguish. And I guess the last thing that I wanted everybody to think about, especially again with children, is that we often teach people, well, if they deny suicidality and they don't have any suicide attempts, then they're not going to kill themselves. But there's a lot of people who engage in endangering behavior who die, and they're not in any way suicidal. So I would encourage everybody to look at their risk. And I often, when I give talks, I'll talk about, a 14-year-old girl who has mild major depressive episode, who has occasional suicidal ideation with no plans, attempts, etc., or intent. And then you have a 5-year-old who's in a neglectful home situation, who's poorly monitored, who runs out into traffic. Well, I worry much more about the 5-year-old than I do about the 14-year-old. But if we just focus on suicidality, we don't even think about the 5-year-old being at risk. So thanks for giving me the space to talk about that. And I think that your perspective would be of great benefit, I think, especially to a lot of people who are working in our rural and frontier communities, who get very sort of mechanistic, like you're talking about, and your thoughtfulness and your look at people's overall humanity is a really refreshing change.
Thank you, Avi. Thank you very much. And those are all very, very useful observations that I am oblivious to because I don't really work with children. So those are very, very useful. Thank you. Any other comments or?
Let me make a comment, Jonathan. What really impressed me about your presentation is what Avi mentioned, that you can see the anthropological, philosophical, scientific education that you've had, and that's of course the way that you practice medicine. Let me ask you a bit of a more technical epidemiological question, which is where I come from. So yes, at PS we make life or death decisions, right? We make very important decisions, and we do risk assessments. So my question is, are you aware if there's any program that has looked at different scales, whatever you're using, and come up with a probability that this individual, with the information you collected, the probability of this individual hurting himself or herself is such? Is there such an instrument to your knowledge?
The short answer is I don't know. I haven't seen one. And I'm not an epidemiologist, and I'm not very informed on probability thinking. So there may be, but I don't know if there is. I don't know if it would ultimately be based on enough true data that I would rely on it in a sense. So I would wonder about the validity and applying it. So at the end of the day, I think our best instrument is our clinical sensitivity and acumen. But that's, I'm not a methodologist, so I could be on that end of things and wrongly or not aware of any advances.
And also something that Avi mentioned that I think was quite interesting, that we always rely, when we assess patients at PS, the first question, do you have suicidal thoughts or not? And if the person says no, then we feel comfortable. So there, the specificity is so important. to what extent the saying no really predicts that the person is not going to commit suicide. Thank you for saying that, Abby. I was thinking about that. What are your thoughts in that regard, Jonathan, in terms of that specific question that we give it so much importance?
I don't give it much importance because if they're telling me yes, they are suicidal, then I wonder what's their intention. Is it to get in? And if they tell me no, then I wonder, what's their intention to say no. So I usually step over that initial response, and then I'll figure out retrospectively if I want to believe it or not. So I don't give it a what's the word, prospective validity or probability or something like that. So.
One quick thing as an answer for you, Mauricio, is that there are studies that the vast majority of people who make a life-threatening suicide attempt have intense suicidality for less than an hour, and a significant minority have it for less than a day. Very few people have it. So when we interview people and then they say that I'm not acutely suicidal, that's why it's very difficult to predict, because in most cases, it's such a reactive situation.
And it's a cross-sectional measure. Jonathan, you wanted to start on time. You wanted to end on time. So respect to you, we'll end this presentation.
Thank you very much. Thank you.
Thanks so much.
Thank you.